Welcome to Your Health with Johns Hopkins Medicine. I'm Melanie Cole, and today we're talking about regenerative medicine, a field that seems to be everywhere right now, from professional sports to arthritis clinics to social media. Joining me is Dr. Bashir Zikria. He's an orthopedic surgeon and an orthopedic sports medicine specialist at Johns Hopkins Medicine. Dr. Zikria, welcome. Thank you so much for joining us today. So start by telling us, what is regenerative medicine? We're hearing this term bandied about. Tell us a little bit about how it's evolved, what it is, and how it's really evolved into something that's become pretty exciting in orthopedics.
Regenerative medicine is essentially a new field in orthopedics. It's been around in other fields for a while, but in orthopedics, it's come around to using the body's own biology to reduce inflammation, relieve pain, and promote tissue healing. That's what regenerative medicine is. It doesn't regenerate the joint. It actually makes an environment for the joint to actually heal better. So that's what we always talk about. And I always equate it to, is like if you have a field and you're trying to plant flowers or plant crops, it's nice to have a good soil, but if you actually bring in fertilizer and make the soil much healthier, and so the plants can flourish and or the crops can flourish, that's what regenerative medicine does. It gives that joint or the area in the orthopedics a secondary chance and even a chance to heal better with a better environment. And that's where regenerative orthopedics came in. And it's become popular because in certain aspects of the joints that we've seen, it not only relieves pain, but it gives a better environment for it to heal.
Yeah, it's really exciting. Doctor, so when we think of healing, as you're talking about, so we're not just managing the symptoms, which is what we've always thought of in orthopedics as helping to fix an injury. This is really the body correcting itself, right? So we're learning more and more about this, but help us to understand what happens when we injure a tendon or a ligament. How does that happen in our body? And then how does this come in and help us to heal ourselves?
Right. So normally when you get injured, you start with an inflammatory process, right? The blood flow comes in there. And usually we sometimes call that the painful phase, right? You get an inflammatory response, healing cells arrive, the blood flow goes there. And then your body lays down new tissue. We call that the repair process. And then as the tissue matures, we call it remodeling, right? The regenerative medicine is actually puts the flow of these regenerative products to heal the tissue better. It actually brings in healing material, cells, helping lay down new tissues. It actually helps with relieving not only the symptoms, but also making an environment or a regenerative environment to heal better, using the body's own cells to heal much better. So, for example, if you have an injury, you bring in new cells in. This is actually bringing in more of those healing cells.
What type of conditions would it be most useful for?
In my opinion, a lot of times in the past, we used to use conditions where we used to use cortisone, right, to decrease the symptoms, right? It didn't do anything for the healing. It did more or less to improve symptoms. Regenerative medicine has shown that in certain conditions, and you have to be within this inclusion criteria, you want to be, most importantly, is to be diagnosed correctly first, right, with the right condition. Now, if you fall within those conditions, then the regenerative medicine can actually be beneficial for you because it not only help relieve your symptoms, but also make an environment that your body can actually heal itself with your own tissues. And that's where I think it comes in. But it's important to be diagnosed correctly because a lot of problem, and we've seen with regenerative medicine in the past, was that people were using it for everything. Now that we're getting much more evidence-based with it is because we're making the inclusion criteria much more stringent, right? First, be correctly diagnosed and it'll work with you. For example, osteoarthritis is one condition. X-ray findings we describe from Kellgren 1 to 4 or 0 to 4, but we go Kellgren like mild to moderate osteoarthritis would be actually a good area. We say Kellgren KL 1 to 3. So it's just mild to moderate osteoarthritis that it's shown some evidence-based medicine to decrease the symptoms and improve the inflammatory response and make the environment better. We used it in the past. There were some good studies for tennis elbow, like tendinitises, where you fall within a good category. and it actually can help with that, like tennis elbow as well.
So, Dr. Zikria, pain is somewhat subjective. So, when is it a good time to seek an evaluation at Johns Hopkins Medicine? When you're speaking to patients now, what symptoms would you like them to be on the watch for when we think of osteoarthritis? And you mentioned tennis elbow and the things that it's most beneficial for. What do you want patients to come in with when they're describing their pain or their limited range of motion?
The things that we always recommend when you come in, if you have pain and swelling for several weeks, not just 1 or 2 days, but for a few weeks, swelling in the knee, loss of motion, weakness, instability, catching, locking, or any discomfort when you're doing your activity of daily living. What I always tell people is like, if you can't do something that you want to do and you were doing it before, and if you're automatically limited, give it a few days. If it doesn't get improve, then it's your time to see the sports medicine doctor. And I always tell people, we don't treat the disease as much as we treat the patient. So when you have pain, symptoms, and then you can't do what you want to do and you're limited, that's when you should come in, right? And I always say swelling is key, catching, locking, pain that doesn't improve, it's or it gradually worsening, and the other things, especially in your joints, and when you're starting to lose motion or weakness, those are things that I always recommend people coming in for.
Well, it's really about quality of life, isn't it? I mean, I've seen
Right.
patients over so many years when they can't bend down to pick up their grandchildren because their knees aren't going to let them or they can't get up off the floor. Those kinds of quality of life, the real functional medicine is what you're talking about here today. So you mentioned PRP. Speak a little bit about the types of treatments that are available in the umbrella of regenerative medicine. And PRP has gotten a lot of play lately, so speak about platelet rich plasma, what that is, and how it helps.
So regenerative medicine is a large framework, but PRP is the one that 90% of publications in evidence-based medicine we have is on PRP. PRP is platelet-rich plasma. It's essentially in your blood. We have blood cells and we have plasma. And when we take the plasma, we say platelet rich plasma. What we do is concentrate the number you have in your blood. So there's different definitions. One was 2.5 times your blood value or 3 times your blood value. So what we always say, it's concentrated plasma from your blood that has more platelets. And these platelets bring in healing modulators. They bring in growth factors and healing factors that come in and they actually support healing and changing the environment of that area where they're injected to.
When we think of concentrating those components for the patient's own blood, as you've just described, what can patients realistically expect? And how do you manage those expectations? Tell us what happens on the day that they may come in, as you've talked about patient selection and the importance of that inclusion criteria. What happens when they come in? What does that day look like? And what can they realistically expect?
So the first thing is we want a correct diagnosis, right? So to make sure it's a condition that, for example, platelet-rich plasma has some good evidence-based medicine. The second thing I always tell patients, this is unlike cortisone. When you inject cortisone or lidocaine, you get instant improvement. That's different. That cortisone is just to decrease the symptoms. This is to change the environment. So it takes several weeks, 4 to 6 weeks. So when a patient comes in, we tell them the first thing we always do is try to make sure we have a correct diagnosis between clinical exam and an imaging. Once we have a correct diagnosis, then we proceed with discussing the options. And platelet rich plasma essentially is what we take some blood from the patient and then we spin it in a centrifuge. And once we get the concentrated form, then we inject it. And when we inject it and we let patients know that it takes at least about 3 to 4 weeks to 4 to 6 weeks to make sure we get some improvement. And those are the things that we do. And one of the other things I always let patients know is that it's the advantage of this is the side effects are minimal, maybe some injection pain, but it's your own, as we say, autologous blood. So it's not something synthetic, not something that we put in from outside. It's your own tissue, and it stimulates your own tissue to heal.
So, doctor, when we hear about cortisone shots, right, there's a limit. And we've always heard orthopedic surgeons and sports medicine specialists tell us, oh, you only can have a certain number of these in a year. With PRP, are there limits to this? And is it something that needs to be redone on a regular basis? Tell us about that.
So essentially, we have to make sure that you respond to it, right? We have a variability in responding. Now, if you respond to it, we want it to last at least about a year to improve. The main goal, I tell people, it doesn't regenerate new tissue, doesn't change, reverse the clock. We're trying to delay or prolong what you have in the joint as long as we can with minimal symptoms. So we want to like extend. So the most ultimate goal is if you have, say, for someone you're injecting with osteoarthritis, you want to delay them from getting a knee replacement or any type of surgery. So we always say if it should at least work a minimum of 6 months for me. My philosophy is, and if it does, then we can see how much longer. Hopefully a year, and then we continue to prolong as long as we can, and as long as it can maintain it, but it won't reverse the clock. It's not going to make an arthritic joint non-arthritic, but it's to make the arthritic joint healthier and delay progression. That's the ultimate goal.
Well, it certainly is the ultimate goal. And if you were to say, what are some of the most common misconceptions that you hear from patients about stem cells and regenerative medicine? Because I know what I've heard over the years, but what have you heard as the common misconceptions?
One, I think when you see in magazines or even in like commercials, you see that it regenerates tissue, regenerates the joint. That does not happen. It doesn't reverse the clock. Even when we consider that's PRP, even when we consider stem cells don't work by regenerating the knee. What it does is works by signaling the cells in your knee to heal. That's what stem cells work by. We call it like the paracrine effect. So it's important to understand that we're trying to delay and prevent progression. That's our ultimate goal. As we've improved in the future, there's some ways to regenerate tissue, or we call it cellular restoration, but we're a little bit away from that without surgical treatment. Non-operatively, in like when injection therapy, we're just trying to delay and prevent progression. And those are the most common misconception I hear is like you'll see an X-ray of someone with bad arthritis, and then the next one they got an injection and their arthritis was gone. That does not happen. Again, it's treating the patient, making sure we manage their symptoms, making sure we prevent progression, making sure that we can get them back to doing what they want to do.
Well, certainly it's that comprehensive approach. Now, when we think of regenerative medicine and all the exciting things you're discussing here today, how does that play with adjuvant therapies, the typical traditional therapies that we know about, physical therapy and, possibly other interventions, medications, anti-inflammatories, you mentioned that a little bit earlier, and even possibly surgery. How do those all work together?
I mean, it's essentially a part of a comprehensive treatment plan, right? So physical therapy is always included. Just by doing physical therapy, you can unload a joint up to 30%. So that helps. I always tell people that your joint is only as good as the muscles that move it, right? If you don't have good quality muscles that move your joint, then the joint is actually useless, right? Because the muscles are what move the joint. For example, we don't do knee surgery unless we know the muscles are healthy, so we can do a complete knee replacement or knee surgery. So we need the physical therapy component always. Anti-inflammatories, one note is when you do PRP, we kind of limit anti-inflammatories for about 6 weeks because we don't want to, it's considered platelet-rich plasma. The anti-inflammatories can affect the platelets, so we kind of limit anti-inflammatories during that time frame when we do PRP. Afterwards, we can use it. And I think surgery is always the last resort. I mean, we get to a point where we have to do some type of cellular restoration or some type of surgical procedure, but it's part of the comprehensive plan. This is where we start and this is where the ending is. And I think it's important to understand, we always say there's an end to a journey, but the journey in the end matters the most. So it's part of the journey we take with the patient.
Well, and it's also really that multidisciplinary whole patient approach that you were describing because
Right.
there's the physical therapists. There's so many people involved in that team and that comprehensive approach. Now, looking ahead, Dr. Zikria, in the field of regenerative medicine, and there's so many exciting things on the horizon, really, like biologics and tissue engineering. I mean, we're throwing out these terms that sound almost sci-fi, right? What excites you? And then even if we think of AI and how that's coming in and adding to your surgical armamentarium with robotics, I mean, your field is really so exciting. What's exciting in regenerative medicine that you're looking forward to?
So first of all, as an orthopedic and sports surgeon, cartilage surgeon, I like the initial aspect that we're starting. I think this is just the beginning with PRP and then signaling stem cells. But we're getting to the point that we're becoming more precise. We're actually getting, we call the delivery mechanisms to cells that they can actually to stimulate healing. We can actually predict it to maintain these cells to make more cartilage. That's one area we're at. We're actually even getting to, how 3D printing of cartilage. Cartilage is very heterogeneous when we put it in, but it has a very specific plan. So we can actually describe and actually make these 3D models of cartilage. And even AI. AI has become very well for predicting whom's going to progress, who will not progress. The more data you put in it, you can predict, like this person has a small lesion in their knee in this area, they're 20 years old, and when will this progress? So AI is coming very popular for prediction. But as far as just surgical also, we're getting to the point where we're actually getting to grow cells, biopsy cells, grow them, and then put them back in the knee. And the problem with that was that once we get to 3D modeling of that, we actually look at someone's knee and actually begin to rebuild that knee the way we want to rebuild it. So we're getting to the point where we're improving, and there's so many. And if you look at, there's almost like over 1,000 clinical aspects to around the world on just this regenerative type medicine studies going on.
It's true. I mean, it's such a burgeoning field and really amazing the technology that's coming out, and it's coming out so quickly. So, doctor, as we get ready to wrap up here, for someone listening who has chronic joint pain or a sports injury and is considering looking into regenerative medicine at Johns Hopkins, tell us a little bit about what you want them to know. If you could leave them with one message about this field and what you do and all of these exciting things that we've been discussing, what would that be?
So the first thing I always tell patients, make sure you see a physician and get the diagnosis correct, right? Once you have the diagnosis, regenerative medicine is an option that can actually decrease your inflammatory response, help your pain. But the most important thing is you have to remember what you want to get back to. If you're limited in what you want to do, there is an option that you can actually decrease your inflammatory response and not just mask the symptoms, but prevent progression. And those are the things I always tell. Be skeptical of anyone promising to grow new cartilage or to make a new knee or promise you long-term longevity without giving you actually evidence-based data. But we have data now, some evidence-based data that can show for in the right diagnosis, the right patient, and where their limits are, that we have an option that can prolong and delay any type of surgical procedure in the future.
It's true. Thank you so much for joining us, for sharing your incredible expertise with us today, and for helping us to better understand this rapidly evolving field. It's so exciting, Doctor, to hear where regenerative medicine is making a big difference today and where the science may lead us in the future. Thank you so much again. And for more information, please visit our website at hopkinsmedicine.org/ortho to get connected with one of our providers. I'm Melanie Cole, and that concludes today's episode of Your Health with Johns Hopkins Medicine.